Hello again, this is Grant Swartzwelder, and welcome to another episode of Oilfield Strong. Today we're going to talk about something that isn't really typical for most of the episodes that we've done so far. It's going to be talking about health insurance and benefits and how it affects the oilfield and oilfield companies. As a company owner, I find that health insurance and the related benefits are so important of maintaining for employees, but also so expensive, and it really affects my profit and loss. When I was talking to our guest today, really discovered that there's a lot of little games that are being played out there, and there's reasons for health insurance costs to be so expensive. So today we're going to learn some of those little interesting tidbits, hopefully learn some ways around that. And that way I think we'll be better educated as business owners and be able to really optimize the health insurance costs, but also the benefit that we provide our employees. So today we're lucky enough to have Michael Knize, who is with McAnally at Wilkins Insurance. Been doing this for many years. Full disclosure, is working with me on our health insurance. And so, Michael, really glad you're here. Really want to understand kind of what you're seeing initially with the health insurance. From my standpoint, it seems like it keeps going up and up.
Hey, Grant, how are you? It's interesting from an inflationary standpoint. The health insurance market far outpaces just the general federal inflationary rate year over year. And there's a few reasons for that, but generally if you're a business owner and you run at an 80% loss ratio, which I would consider as average, you're going to see an 8 to 10% increase year over year. The reason for that 8 to 10% increase is, quite frankly, because if you have a knee surgery this year, you have the exact same knee surgery next year. It's going to be 8% higher in cost. A lot of that has to do with hospital fees that they're building in. The hospitals are struggling financially. The other part of this that people don't think about is there's a reason they target that 80% loss ratio. And for people who may not know, an 80% loss ratio means simply that the insurance carrier paid out 80% of the total premium that they took in. They paid it out in claims.
And that 80% is kind of the target the insurance company has. They don't want to get beyond that, or otherwise they'll really up your rate.
That's correct.
Okay.
That's correct. And there's a reason they don't want to get beyond that, and that's the nice little thing called the Affordable Care Act. The Affordable Care Act, when that was put into place, stated that insurance carriers for small and mid-market groups have to pay out 80% of the total premiums they take in claims. For large groups, it's 85%. If they go over those targets, they actually have to rebate. And this has happened a few times. United Healthcare, it's happened a few times, at least in the past 6 or 7 years, where they had to rebate their customers for the amount that they did not deliver on in terms of claims. If they paid it 79%, they have to rebate 1% to get them back to that 80% threshold for their whole book of business, not for individual companies.
Right.
The funny part about that is that when they were putting this in place, they didn't think about the flip side, which is you've basically told an insurance carrier that they can keep a 20% margin. You being a business owner,
Yep.
If you were told you can only keep a 20% margin, it can't be higher than that, then it really disincentivizes you to find ways to run a leaner business. The only way that your actual dollar margin is going to go up year over year is to be able to increase your premiums, but also pay out more at the same ratio. So in my eyes, there's really not a lot of incentive for an insurance carrier to keep costs down from the provider side, as well as the hospital side, as well as the pharmacy side. Because as those rates go up, they can raise their premiums to cover those rates, and now they're keeping 20% of $200 versus 20% of $100.
So no motivation to keep price lower. If anything, there's motivation to increase it.
Absolutely.
And is that through all the sections of health insurance, hospital, medical, pharmacy? It all works that same way?
Yeah, it all works the same way, because when they're looking at the medical loss ratio, that medical loss ratio includes everything they paid out in claims, whether it's a doctor's visit, whether it's a surgery, whether it's claims towards a facility, or whether it's claims towards a pharmacy. So they are incentivized, in my eyes, for that to keep moving up and up and up. They still keep a 20% margin, but it's an actual dollar amount that's larger year over year over year.
That's amazing. So within health insurance, you've got hospitals, you've got physician and primary care, and then you have pharmacy. Are you seeing different things happening for each of those sections?
Well, really, you're going to see the hospital claims and your provider claims are all going to fall under medical. Pharmacy is going to fall on its own. What we do see is that pharmacy is far, far outpacing what the medical claims are.
And why is that?
Well, quite simply because you have a few companies that are producing a lot of these drugs, like Humira, which is one of the best-selling drugs in the United States history, and in medical history across the world, which treats a lot of things. It's an autoimmune drug that can treat plaque psoriasis, rheumatoid arthritis, and other things, but it has broad uses. And they get a patent whenever they introduce that drug, and until there's a generic out there or a biosimilar, then they can charge pretty much whatever they want. And in fact, if you saw this past year, Trump's executive order that he signed stating that we needed to bring the drug costs in line in the U.S. with the rest of the world, actually what's happened is those manufacturers are just going to the rest of the world and raising prices to the U.S. prices. The U.S. prices really aren't coming down.
They're not coming down because the research for this, it looked like American pharmacy rates are 2 to 4 times what the world's paying.
Oh, without a doubt.
Okay. And so you're saying that that's not going to be reduced. It's just the world.
The story is that it should bring a reduction.
Right.
But the mandate was that our prices are in line with the rest of the world. So there's 2 ways that can happen. Our prices come down, their prices come up. And the argument against that mandate, in fact, from a lot of people were that some of these other countries and countries that have people who are less fortunate and maybe can't necessarily afford what a lot of Americans can afford, they're being punished by this mandate because they are bringing those prices up, which is making it harder for them to get those drugs.
So the other thing when we talk about pharmacy that I always hear about is the pharmacy benefit manager and how they're kind of a middleman that really jacks up the price because they're adding an extra layer of cost. First, is that true? And then you might also explain what that is for our audience.
Yeah, so the pharmacy benefit manager, every plan has a pharmacy benefit manager made in. When you're looking at your health insurance plan, whether you are fully insured or whether you're self-funded, you have administrative costs, you have, which are going to include to a pharmacy benefit manager, as well as administrative for handling claims, processing, things like that. Then you're going to have your claims cost as a part of that, as well as you have you could have a stop loss carrier in there if you're self-funded as well. So you've got those aspects of it, and the pharmacy benefit manager, they actually, whenever I told you that medical and pharmacy were classified as 2 different things, and they're the only 2 classifications when you look at a medical stop loss ratio. Pharmacy is managed by what's called a pharmacy benefit manager. And what they're supposed to do is price out the drugs, resource the drugs. When claims get presented, they handle the claims for those different pharmaceutical prescriptions. And then in addition to that, they source those drugs, they negotiate the prices. They also negotiate rebates as a part of that. Okay. When you're in a fully insured program like a Blue Cross or a United or an Aetna or a Cigna, you can bet that if they don't own the whole pharmacy benefit manager, they own a big piece of it. So they are incentivized by those rebates as well. They do have to count that toward that 80% loss ratio, those pharmacy rebates that they get back. But the business owner doesn't see that coming back to him as he's paying those large premiums.
So the employee or the company is paying for the list price and not the net price.
That's correct.
Okay. That's correct. So who gets the rebate?
The pharmacy benefit manager gets the
very
rebate.
Nice.
Yeah.
Good for them.
Yeah. It's just another way to make money. Like I said, they do have to count that toward that medical loss ratio, but you really have no control as a business owner in helping keep those claims down. The way you can have control is if you're in a self-funded program where you have a lot more insight as to what is going on within your plan. And if you have a standalone or third-party pharmacy benefit manager that is not attached to a large carrier, they're incentivized. They get paid on a per employee per month basis. If the contract is done properly, they get paid on a per employee per month basis. And then those rebates are set up at 100% pass-through so that they come back to the employer. In addition to that, when you have those third-party pharmacy benefit managers, you can do things like international access to drugs, where you can source them less expensively than you can here in the U.S. You can direct people towards biosimilars and changing, taking medications that may be 2 or 3 pills that make up what this one pill does.
Didn't the state of Texas vote on something like that, where they were trying to bring in Canadian or international drugs into?
I had not seen that.
Yeah,
So
I had heard that was part of because they're trying to bring in from cheaper places that drug to get the cost.
Yeah, but if you're in a contract with an insurance carrier and they don't allow for that, it doesn't really matter what the state's going to vote on. If your contract with the insurance carrier is that you use our pharmacy benefit manager, you're going to get those drugs from wherever the pharmacy benefit manager sources those drugs.
So they have the control.
They do have the control. That's where you're in that contract with them, as to where if you are a self-funded platform and you have a third-party pharmacy benefit manager, you've got more control over them and directing them on how you want to treat your members, your employees, and you incentivize employees. You waive costs for them because you get those drugs that are hitting your bottom line at a much deeper discount.
And several things to unpack in that, but let's talk about, I think, what you alluded to there. And in a way, that's the name brand versus generic, and being able to allocate or hopefully get your employees to go with the cheaper, which should be the generic.
Right. And most insurance plans now require that you use a generic if it's available. Okay. If you're with a United Healthcare or a Blue Cross and there's a generic available, then they require
they'll just automatically do that.
Absolutely. In fact, that's probably the biggest frustration that we get from members of health insurance plans is complaints, because they believe, for whatever reason, that a brand drug is the one that doesn't give them a headache, or they get some sort of different relief from it, when in reality the generic is the exact same formulary as the brand drug.
And the brand name's probably also advertising, and so you see it on TV.
Yeah, and you'll see those advertisements. Everything you see on TV are the most expensive drugs.
Sure.
And those are the ones that are not available in generic yet.
Okay.
Those are the ones that are not available in generic yet, which is why they're pumping the advertising dollars in. Because when the generics hit the market, the revenues for that drug fall off a cliff, and they better have a new drug coming into the market to fill their revenue coffers.
So the theme we're talking here is pricing and how that's determined, and let's dig into that a little bit more, where it doesn't seem as if pricing for pharmacy, for hospital, for special care is really that transparent. And I've heard examples where you can go, and I know Mark Cuban really loves to talk about this, where if you go to get an MRI here, but if you go down the street, it could be a lot less. Is that true? It's
absolutely true. You could Google an MRI for an elbow or a knee or something basic, any sort of orthopedic issue. You could Google that MRI and you'll get a range from $500 or even $300 up to $7,000.
And so would they still take that cheaper one, still take the insurance, or is there a limit that now you're out of pocket on that?
The cheaper ones usually will take the insurance.
Okay, so that's not an issue.
But the issue is that if they're contracted with the carrier, if the highest one, the $7,000 one, is contracted with the carrier, and the member on a fully insured Blue Cross Blue Shield plan, let's say that their copay on it is $500 for that MRI. Well, it doesn't matter where they get that MRI done. They're going to pay their $500 copay. So they're not going to look as the member as because, we all like to believe that our employees have a vested interest in our company.
Sure.
But when it comes to their health, they trust their doctors, and whatever the doctor tells them to do, they're going to do. And if the doctor tells them to go across the hall, which he most likely is going to do, they're going to go across the hall. And the reason he wants them to go across the hall is he owns a piece of that machine, at least a piece of it, if not all of it. And so it's a very incestuous relationship.
And how do you fight that? Because you normally don't question your doctor and say, no, I want to go here or I want another option.
Well, that's the problem, is that most people don't know that they should and they can question their doctor. Whenever someone wants to when a doctor tells them to go get an MRI, that's a prescription for an MRI. You can go get that filled anywhere else. It's interesting that you brought up that no one questions their physicians. They also don't question their physicians' offices. And sometimes you'll go in and the physician's office will have a much lower cash pay price than they have negotiated with the insurance contracts.
Really?
There's a reason for that. Go back to what we talked about at the very beginning. Insurance companies aren't necessarily incentivized to negotiate the lowest price. And a lot of people don't know that it is your patient's right that if they have a lower cash pay price, you can ask for that cash pay price and tell them that's what you want, and they have to honor that cash pay price.
Which sounds very logical, very easy, but it seems the bureaucracy and the headaches associated with that really kind of push against that.
Yeah,
and that's probably like a lot of things where you just have to keep pushing. You have to self-advocate to be able to get it.
And the problem is that most people, look, I'm in the health insurance industry.
Right.
This is what I do, and it's very confusing.
Yep.
I've had situations within my own family where we've been overbilled by a provider, and I had to do my own research. And had I not been in the insurance industry, I would not have known to fight it. And so I think it is a habitual thing where people get overbilled by providers and they don't know about it, and they don't know what to advocate for because it is so complex.
And it seems like this could all come together with all of the consolidation associated with the industry. When you only have one or two players, you don't have a lot of options, and it's a huge company, which makes it very difficult to really figure it out.
You've got four players in the marketplace whenever it comes to commercial insurance: United Healthcare, Aetna, Cigna, and Blue Cross Blue Shield. Unless you are self-funded.
Okay.
Unless you are a large enough group, which I would recommend, that's really groups with employees enrolled 100 or more. You can do it with fewer employees. You just add to your risk when you have fewer employees, because that big cancer patient or that big $4 million baby is going to have a bigger effect on your overall loss ratio and what your projected claims and your exposure are, versus if you're spreading that out amongst more people. You have 100 people, 200 people, even more predictable, 300 people, even more predictable as you move up the chain.
Well, another theme here of the pricing is it really doesn't seem like there's a lot of discipline from cost. And you talked about the 80%, that kind of reflects that. But even like on new drugs, how do you really price the research associated with that? Just a whole lot of areas where it just doesn't matter what it costs, because by definition, it just gets pushed out to the employer or the employee, or ultimately both, I guess.
That's correct. You don't have a lot of control of what's going on. Once again, unless you are in some sort of self-funded program where you can start to steer and get advice. But if you're in a fully insured program, then you're beholden to whatever they're going to negotiate on the contract side.
Right.
And you have no control over those prices. I think I've done this with you. You can go through reports that the carrier sends you, and it's a 50-page report, and it has a lot of information in there.
Yep.
There's just not a lot you can do with it. Now, you can strategize on how you handle high claimants, and you can do some things to mitigate your costs and create some flexibility in there. But in terms of if everyone's within the same plan and we're moving forward, there's not a lot you can do from a cost perspective. What your cost is, your cost is. Whenever I say that, we can look at, I can look at a plan and I can tell you if they've got an 80% loss ratio, they're going to get an 8% increase. Actually, if they're over 50, Blue Cross Blue Shield is likely going to come back with a 16 to 17% increase. We're going to look at it. We're going to justify it back to Blue Cross. We're going to negotiate it down, but we're going to wind up at an 8% increase because that's on trend at 80%. If you're below that, if you're at 70%, we expect you to be below trend. If you're even further below that, then we're looking for flat renewals and possibly decreases if you're way below, although not really many people see a decrease in their overall.
I was about to say, when's the last time someone saw a decrease there? It's the other thing that always befuddled me, and I saw this more on the equipment liability side. Tell me if it's true on the health side, is that when you're quoting it out, that you have to show the quotes to them. So in a way, they kind of know what they're bidding against.
Yep.
Explain that.
It is.
And how,
it is.
Because that seems so wrong in an open market type environment. Now, I'll get off my soapbox now. But
I'll get on my soapbox because you brought it up. We're not in an open market.
Okay. It doesn't sound like it.
And whenever I say we're not in an open market, the Affordable Care Act tells these carriers what they have to cover. They preach that, it's because we want to cover pre-existing conditions. Well, pre-existing conditions have always been covered as long as you showed that you had continuous coverage leading up to it. If I switched companies and I had a pre-existing condition and I could show that I had coverage with my prior company, then the new insurance company would take me.
Fix it up.
It's just like life insurance companies. They don't want to wait until you're diagnosed with the terminal illness for you to sign up. It's not insurance anymore. It's a guaranteed payout.
Right.
And when you look at that, and if you think about life insurance companies, if someone's got $1 million policy, from a health insurance standpoint, you could have someone with a chronic disease or even something that's acute that has to be treated that leads to long hospital stays, possibly in the ICU for several weeks. And those can lead to claims that are millions and millions of dollars.
Clearly.
But these chronic problems, that's what's happening is that these insurance companies are having to take individuals who don't have insurance that aren't signing up until they're sick, which at that point, it's not insurance anymore, it's a guarantee. I believe that if they actually open the market up, and we did have a true open market where an insurance company could come in and say, hey, I'm not going to cover pre-existing conditions unless you show that you've previously been covered by insurance. And you know what? We don't feel like we're going to cover these certain things, and people actually have a choice as to who they want to take. It's fine if you have a layer of higher cost insurance where people are guaranteed certain coverages and they want to go that direction, fine, but let's make it to where it's the patient's choice on which direction they want to go.
Did I hear with what you just said that because, and I might be jumping out beyond my skis here, wouldn't be the first time, but that because other people might not be covered, that there's kind of a sharing or a shifting?
Oh, without a doubt, there's a sharing. And I mean,
so with all these people that aren't insured, or even if they are insured, that
I would look at it more from the uninsured, right? Where if what I'm saying is accurate, which I believe it is,
okay,
that it is a guaranteed payout when someone waits until they get sick before they get insurance.
Or don't get insurance. They just go to Parkland or whatever and
correct.
Pay.
And they haven't taken care of themselves. Who's going to cover those costs? You have to spread those higher insurance costs amongst the general population. If you are going to cover people with pre-existing conditions that haven't been taking care of themselves, and if they didn't have health insurance in place, they probably haven't been taking care of themselves. And it makes it a worse scenario.
So not to get political here, but does that then lead you to saying that that's why you need kind of Medicare or some type of health insurance for all, and then you kind of base load that?
Well, I'm not for Medicare for all.
Okay.
I think that.
No, and I have no position. But if you got that loading going on, you need to do something about that, or it'll always be an issue.
You
And
do.
so I'm just trying
You
to figure
do.
out, how do you do that?
I don't know. I mean, I don't know the true
Come on
answer
now,
to
you're
that.
supposed to have all these
Yeah,
answers.
I don't
because
have.
clearly Congress
have
doesn't
all.
have any clue, so it's up to you.
I don't
Mike.
have all the answers.
Okay,
but I will.
well,
I
I'll
will tell
accept
you. I
that.
think that what we're doing now, in terms of health insurance, is a bad idea. And I think you, as a business owner, and all of the other business owners that are out there would agree with me. I've yet to meet with one of them who says that we have a good deal on our insurance.
Yep.
And the costs keep going up and up and up and up.
Yeah, it's
And
a steady incline.
And it's not going to stop.
Yeah.
I mean, I believe the first time I met with you, I told you I can't guarantee you any cost savings. And by the way, I'm probably not going to save you any money.
And you lived up to that, Michael.
Yes, and I've
so
lived
thank you.
up to
No, and I'm kidding, but I understand the market, and that's why I wanted to have you here. So let's talk about the whole employer issue there, because as an employer, I'm trying to have a good health policy benefits for my employees. I have them pay some in a way that makes them oblivious to all of the increase. Yeah, they get, say if they're paying 10%, well, they pay a little fractional increase, but so small to the 90% that I'm paying or that an employer is paying. So in a way, having an employer policy in a way makes it so that the employee has no clue what it's really costing them.
Oh, you're absolutely correct in that. I mean, I don't think the employee understands how much employers contribute to their costs.
We used to, when we initially, sorry, Michael, we used to do 100%, and we changed it to 90%. So at least they saw a little bit of it so that they knew that there was some value to that, because then it became kind of just a norm that it was just free.
Right.
And it's like, no, it's not free. Right.
Well, I think actually that's a good idea, because I believe in that as well, that they have a little bit of skin in the game. We work solely in the oilfield service industry and with oilfield service clients. And I can tell you the populations, the young males who are invincible, they just don't care. And if they're not willing to pony up $10 a week to cover their insurance, then why should the employer care what they're providing them?
Yeah.
Or they'll come in and they'll ask about benefits, and then they'll turn around and leave to go across the street for $1 more an hour, because what they really care about is the bottom line on the paycheck. So as it relates to what you're doing in terms of covering the bulk of that cost, you're right. They are completely shielded from the actual cost, which is why they will go from one employer to the next and then complain to the new employer that my employer's insurance rates were so much cheaper than your insurance rates are. Well, that's not necessarily true. It's the amount the employer is contributing to that plan that makes up the
and what the
difference.
deductible is and what type of coverage. And there's a lot of the proverbial devil in the details on that you have to really understand.
Yep.
The other, while I'm ranting here, is that we try to take a lot of care in looking at how many checkups and preventative type work they do, because it's covered by insurance. And the idea is if you go and make sure and get taken care of on a preventative basis, that's going to save you later. Also, I'm paying for it, so go get your checkup. But that's another thing within the oil field that they just don't use that.
Well, I'll give you a big reason for that, and that's if they're going to go see a doctor, that's usually between 8 a.m. and 5 p.m. Monday through Friday. And you know that your oil field employees,
they've got to be out in the field.
They've got to be out in the field, and they're earning by the hour, and they want to work more, and they can't take off. That's why we've seen such a surge in use of urgent cares, which has always been another thing that drove costs, were people using the emergency room.
Right.
And I think not just ourselves and the employer groups that we work with, but other brokers and insurance carriers have done a really nice job of communicating and pushing urgent cares, but it takes time. And the one thing you don't have is control over what your employees' decisions are.
Yep.
Right. So as an employer, you can educate and you can encourage the group as a whole. But in reality, the people who aren't going to do it aren't
gonna
going to do it. You don't have a
And you bring up a point about urgent care versus emergency type care. And that's something that we've really tried to focus on. Explain that, the difference in that, because one is definitely a lot more expensive. And how do you identify one versus the other, and when do you go to one or the other?
First of all, the difference is price for the most part, right?
And that's the emergency.
A true emergency is going to be a compound fracture.
But we're talking like a standalone building, and some are emergency based, and some are urgent based.
Yes, don't ever go to a standalone emergency room.
And why? Because of cost.
Because of costs. Now, if you go to a standalone emergency room, ask for the cash price. You can certain times, there are going to be times where there's not a 24-hour urgent care, and maybe that standalone emergency center is the only place you can go at 1 o'clock in the morning because you're so sick and you need some medication.
Sure.
Ask them for the cash price. You're going to pay them $150 and you're going to get out the door. If you run it on your insurance, it's going to be run as an emergency room, and you're going to have a $500 copay, plus you're going to pay deductible and co-insurance on most plans. So those standalone emergency, well, actually, if that's only if it's an emergency. If it's not a true emergency, actually, it's going to be covered as out of network. Those standalone emergency centers are seldom an in-network facility with your carrier.
Oh, very nice. And so how do I tell that that's an urgent care versus an emergency?
If it says emergency room on it, stay away from it unless it's attached to a hospital.
So it needs to have an emergency on it.
Yes.
Or, doesn't need to, but that's what you look for. And then otherwise it's an urgent care.
And you want to clarify, right? You want to do two things. When you go into an urgent care, you want to ask them, are they classified as an urgent care? And secondly, not do you take Blue Cross Blue Shield if that's your insurance carrier, not do you take Blue Cross Blue Shield, because everyone's going to say yes to that.
Sure.
It's, are you in network with Blue Cross Blue Shield? Are you in my network? And have them run to see if it's in network. And if it is, then you're going to pay your $35 or $75 copay, however your plan is set up.
And one of the helpful hints for our yards scattered all over Texas, New Mexico, we've identified those beforehand and given lists to our employees so that they will focus on those, as opposed to, because if you have an emergency, you've got an issue, you're going to just go to wherever you go.
You go to the closest facility.
Yeah.
You don't worry. In an emergency, everything is covered as in network.
Yeah.
In a true emergency. Now, a lot of people don't know, when do I go to an urgent care versus an emergency room? If you're having chest pains, you go to an emergency room. If you've got a compound fracture, if you've got major lacerations,
Sure.
you've got blood loss, those are the things to go to an emergency room. If you have a minor cut, they can stitch you up in the urgent care.
Yep.
You can get basic x-rays in the urgent care.
Or cold or flu or any of that
flu.
stuff.
Do not take don't go sit in an emergency room for 6 hours, which is what you will do if you have the flu and go to an emergency room. Don't go sit in an emergency room for 6 hours because you have the flu or because it's a Saturday. The other thing people don't take enough advantage of is the telemedicine option. Every plan out there has a telemedicine option, whether it's virtual or whether it's by phone. Most of them are virtual now. Over your phone, they can be video or they can be text-based. But you can get in, out, see a doctor, get prescribed drugs without ever having to step in an office.
Saving a lot of money and time.
Save a ton of money. Most of those telemedicine programs are free to the member.
Very good. Michael Knize, thank you very much for helping to educate our audience, working with me on trying to improve how we provide those benefits. It's so frustrating, and the more we know how this works, I think not only can we maybe benefit from that, but hopefully we'll also start pushing our Congress folks and others to try to change this procedure or the policies so that we have a fighting chance of actually having a better healthcare system. So thank you very much. If you like what you're hearing, if you think you benefit from this, please pass this on to some other folks and follow Oilfield Strong. We're on all your podcast platforms and on YouTube. Thank you very much.